And the next speaker is Dr. Jason Wang, Associate Professor of Pediatrics and Director of Center of Policy Outcomes and Prevention of Stanford University. Please join me welcome Dr. Jason Wang.
Thank you very much. I'm a physician by training, and I never thought that I would get invited to a Global Semiconductor Alliance meeting to talk about technology. But this is a research that, this is an area that I've been working on for the past 6 years. And I will show you some of the work that we're doing at Stanford and also in Taiwan. So integrating technology into healthcare is actually a challenge and an opportunity. For example, in the United States alone, the healthcare spending per year is $3.8 trillion. That is 16 to 17% of the entire GDP. It is forecasted to go up to as big as 25% of the GDP. So every quarter that we spend in an economy will be in healthcare. But why is that a challenge? I think we have had a lot of advances in technology over the last 50 years. But this next wave, I think, is very special. It involves consumer technology, like Leo was talking about. But really, what are we talking about when we say integrating this type of technology into healthcare? It really has to fulfill some major requirements. So for example, can we integrate it into the clinical workflow of doctors and nurses? Can we put it in the right context for the users? Who are our customers? And this is very important because we might have different types of customers when we're talking about everyday use of technology in healthcare and cultural issues. Can we overcome some of the cultural issues in, for example, literacy and illiteracy, electronic literacy? And finally, I think some of the challenges come around in terms of disparities in technology. So we talk about the digital divide and who has technology, who doesn't have the technology. And in healthcare, we pay particular attention to disparities. Disparities is defined as unequal access to effective treatment. Okay? So if you think about Titanic, there are 3 classes of passengers, right? Who gets on the boat first? Class 1. That's a pretty effective treatment to escape, right? So if you're a class 3 passenger, you're not going to get to the boat. So can we deliver technology into healthcare in such a way that we basically mitigate disparities instead of expanding them? I think that's a major challenge. At the end of the day, technology is a tool. Healthcare and medicine is a human enterprise. Okay, so how are we going to take the advantage of what has been created by the semiconductor industry and translate it into future opportunities in healthcare? So when we talk about a full cycle of care in medicine, we're talking about prevention. Can we use it in prevention, preventing disease from happening? Or can we use it in early detection, such as screening? This is all at the population level, and this will likely take place in the communities rather than in hospitals, right? So then when we're talking about diagnosis, this is when most doctors are comfortable with. Usually it takes place in the hospital, the diagnosis, the treatment. But then this later stage is very important, the post-treatment. For those that have survived, not only it's a survival issue, but it's also return to function. Can people go back to work, or can they go back to school if they are still a kid? And can we support them with high quality of life with supportive care? The bottom is the healthcare environment. So this is rapidly changing because hospitalizations are so expensive, both in the United States and in Taiwan. people are now trying to figure out ways to avoid hospitalization. So that means we're going to be transitioning from one care environment to another. For example, an elderly person will likely go from a hospital or ED, transitioning into an outpatient facility, and maybe transitioning into home, maybe comes back to the hospital, goes more to the outpatient, maybe get followed up in a community clinic for rehab, and maybe at some time are going to be in a long-term nursing home. And so there are these transition states. So how do we integrate the information with the technology, right? So information, technology. So information is the most important part, and how to use technology to empower that revolution. So we're talking about really integrating the care environments, both physical care environments and the virtual care environments. So my work in this area started about 6 or 7 years ago, and I was interested in quality of healthcare for premature babies. I'm a pediatrician. And I noticed that, with, first it was ASUS, EPC, and also Acer, and these are both Taiwanese companies. They have produced a netbook that could now fit into a woman's purse. So that's very special, right? So this is a very special opportunity. Before we used to carry around, clunky computers, and now this is a small one. So I decided that I want to give all the mothers of preterm infants a computer like this. So actually, I bought them computers. I borrowed some money from my department chair. He knows where I work, so he loaned it to me. I charged my credit card, and I bought broadband services to go with these computers so they could take them home. So I was interested in how do we help families get connected, because this is the premature infants, I don't know if you know, is 2 to 1 disproportionately born to African American and low-income families. 2 to 1. So if you grow up in an environment where it's kind of chaotic, it's probably a lot of poverty, you're more likely to have a very low birth weight, premature infant. So, and then later on, the iPad came along. And so we gave people a choice of either a netbook or an iPad. So we gave it to them. And so we started to do studies on the people who have these type of mobile devices, as we call it. And for example, we enroll families basically based on when their child was delivered in the hospital, right? So they say, families will have a premature infant and they will stay in the hospital for about 6 weeks. Usually they were born at 26 weeks, or the youngest are like 23 weeks gestation. Okay, they're like less than 1 pound. You could hold them all in your palm, okay? And then they stay until they are 36 to 40 weeks. They get discharged to the hospital. But what happens to them at discharge, do you know? We would have spent about $250,000 saving the baby and taking care of them in the ICU. Then we will say, bye-bye, have a good life. Nobody knows what happens to them. Nobody knows what are the quality of care that are needed to make sure that they continue to thrive and have a potential to make to be a productive member of society. So some of these problems that these patients have include they can't hear because of the antibiotics we give them, and then some of them are deaf. Some of them have cerebral palsy. They can't really move their arms and legs that well. A lot of them are going to go blind because of retinopathy or prematurity. They were born too early. Their eyes were exposed to oxygen too early. So if you have kids that can't hear, can't see, they can't learn. They can't go to school. So all these things we need to be tracking to make sure they get the follow-up services they need so that we could reverse that. Because if you detect the eye problem early, you could cure it. If you don't detect it, they go blind. This is effective treatment right here, right? So we need to be solving these type of problems. So I gave it to the mothers, these equipments, and I study how they interact with each other. Okay. So basically, we have families that have never met each other talking to each other online for mutual support, because they could join this thing, what we call a parent forum. So these are the families that got trapped at home because if you have a preterm infant, you don't want to go outside because your kids are like in an oxygen tank, right? And people will cough at your kids, so you want to stay inside, right? But if you stay inside, the mothers will become depressed because here are this little baby and you can't go outside and you can't go inside. But what we're also finding is that they use our netbooks and our iPads to watch Netflix. That's beautiful. We're solving maternal depression right here. Okay, that's beautiful. You know, when my RAs came to me and say, you know, they're not using our website on the quality of care follow-up that much. They're watching Netflix, and I said, oh wow, that's wonderful, you know, because we don't have that much content, right? In the website, I mean, we tell them what to do. We help them schedule. We have a scheduler, so they have multiple appointments. So what we help them is to tell them when the appointments are and give them alerts to these appointments. We have YouTube videos on them, so they could click on them, and they could watch infant CPR. How many of you had learned CPR before? One. How many remembers how to do a CPR? Nobody. I don't even remember, right? Because, you know, it's one of those things. It's not that intuitive, but if you watch YouTube, you can learn it anytime. And if you're an infant, if you're a mother of a very low birth weight infant, you really ought to learn CPR on your own time. And we don't do that well because when we're trying to discharge them to get the bed available, we push them out the door, right? We're like, sign here. You know, here's all your paperwork. Bye-bye. Have a good life. Right? So we don't want to do that. So we found that we were able to track how they were using it because they were all in my credit card, okay? So that's why I know. So obviously now there are access to these telecenters, even in Africa and India and many other places. And these things are getting so cheap that it's now going to be ubiquitous, okay? And, you know, we have these iPads now we could explain to patients about their medical condition at the bedside, and we're doing that every day. And here's a Stanford virtual reality surgery. Can we play the video, please? So what we do is that instead of going to the patient code, we do a CT and we reconstruct the three-dimensional structure of the patient's nose so that you could practice on that patient in a simulator once before you actually do it on the real patient. So this is the patient, right? So this is the power of semiconductors, right? Now you allow this kind of computational power to allow basically people to practice on the patient beforehand, right? Through a simulator. Okay, next slide, please. Actually, I could do this. So what we're looking for here is basically, you know, when are these eHealth and monitoring and interconnected health very useful is when you have extreme geographic conditions that you don't want to drive all the way up there and maybe, you know, the patient's okay. You could use that. Weather conditions. And mostly you meet patients in their comfortable domain at their home. So they actually could just kind of, you know, sit there in their home and talking to you instead of driving to Stanford, for example, try to find a parking space and then miss their appointment, you know, become 15, 20 minutes late and get really angry and have to drive back. What happens when you go to the doctors? You wait for an hour and they spend 2 minutes? They say, you're fine. And you're like, that's it? You know, and the next patient is waiting, right? So Johns Hopkins now started to dose, you know, Parkinson's disease in their drugs with eHealth. So they could, based on the way they walk, they could dose the medication, right? Convenience and reach. So you could be a great doctor in your own home. You could wear your pajamas and be a good doctor. You know, all you need to do is make sure something is respectable or just, I do this all the time, you can tell. But there's requirements. You need to be secure. You need to obey the privacy laws and the security laws of HIPAA. Right? What happens if somebody breaks HIPAA? You could get fined as much as $1.5 million a year. Okay, Stanford has gotten fined for that because, you know, most people, you know how they lose their patient information? They lose their laptops. Okay, and so and they have some things about patients in their laptops. So just be careful and encrypt. It has to be reliable. It can't be, some of my Skype calls, where I can't hear anything. I mean, you hear a very high quality one with Daniel Niles just now, but it's not always the case when you're working with technology. And what about things that, for example, if you're going into an underserved area, like going to Africa or going to remote areas. We actually could attach different gadgets. This is the retina, the back of the eye, okay? So you've seen blood vessels. You could do this for diabetes. You could look at the back of the eye for people with diabetes to see if they had progressed. Can we show the video, please? So this is pretty easy, right? It looks pretty easy. And the thing, the beauty of this is that you could see it on your screen here. You don't have to get too close to the patient. Typically, when we look into the patient's eye, we go too close, we're almost kissing the patient. So we have to kind of, tell them, and you have to pop in a mint and things like that before you get too close. And then remote monitoring. So you could improve patient self-management. So for example, you have tuberculosis, right? And they need to take their medicines every day. Well, you could watch them take them, right? Turn on the FaceTime or whatever, Skype, and you just watch them pop that pill in there because they need to take it every day. You don't have to go over there. You don't have the direct observer to the patient's home. That seems like a waste of resources to me, right? And you quarantine infectious diseases. So we have a now epidemic. When it crosses continents, it's considered epidemic. But I guess the numbers are not there yet. A pandemic is not there yet. But what happens for those quarantine, instead of gowning up, you could have them do self-monitoring. You could get the data, right, without endangering healthcare workers. Improve the quality of life. It helps to deal with non-adherence, like the tuberculosis medication. You could catch problems early. So now you get all these sensor data, and you get all these data that you're collecting, a lot of data points, and you could begin to analyze issues that you wouldn't be able to detect before. So I'm a pediatrician. I see patients with asthma, but I want you to just imagine what happens to a typical asthma patient. Most of the time, we don't know what the hell we're doing. We don't know what triggered their asthma. People clean their sheets and for dust mites, and people put humidifiers, people do all sorts of things, and people still have, asthma attacks. Okay, so imagine if you could have mobile app that incorporates the following: individual factors, so triggers, potential triggers. Do they have a cat or a dog? Medication use, are they taking their medicines on time? Do they have stress or anxiety, because that could trigger bronchospasms and trigger an attack? Then you add the outdoor environmental factors like air quality, which is published data, right? You integrate the air pollution index, which is also published in many places, and the particular allergens that you notice in the environment. For example, hay fever, there are different types of pollens that they're seasonal, right? Then you integrate the indoor environmental factors, like anybody smoking at home, right? And the biologic allergens like dust mites and chemicals, right? Every time I go to the clinic, I start sneezing because I know it's the chemicals they use to wipe down the counter. And you need to be able to do that to prevent an attack. So what we're talking about is to move things upstream, to prevention. That's how you solve people's problems. Not to treat them when they're already sick, but can you actually prevent this whole episode, right? And then we want to form an evidence-based prediction tool to track all sorts of triggers to empower patients and providers, their doctors and nurses. So what we're doing is to integrate data and to write source codes to analyze the data, to build models. For example, there could be different types of patients. Patients A could be triggered by molds, dust mites, medication, and anxiety. Patient B would be some of the same ones, but strong odor or respiratory infections or air pollution. So you want to segment your patient population using the data that you collected to tailor it so it's individualized, okay? Not gunshot approach, give everybody more steroids. That's not good. Don't give everybody more steroids. And validate the model. And, when the cloud is more secure, which it will be, I have no doubt, put it in the cloud, and then you don't depend on individual institutions. You don't really care where the patient is because it's all going to set up in the cloud. So we have a laboratory that we started this laboratory called HABIT. It's the Center for Health Analytics, Behavior Interventions, and Technology. So the model, this is at Stanford, under my center. So we're trying to figure out the triggers of things, individualized factors and environmental factors, the treatment outcomes, the treatment and the relationship to outcomes, including the science of pathophysiology and the behavior interventions. If they're taking their medicines on time, if they're doing things to avoid the triggers, and so forth. Now, I'm going to tell you about this, what we're doing for training, right? Because we want to train the next generation of data scientists, of doctors, and of IT folks, right? Typically, when we think about health information technology, we only think about this part. How do you build an app? How do you get programmers and engineers to build an app and design the interface? That's not going to be very useful, I could tell you that, because it needs to fit into the clinical workflow. Nobody wants to enter the data twice, okay? And it needs to have some sort of clinical knowledge that makes sense. So we're creating something called the mini medical school, something called the mini EECS design school, and something called the data analytic module, where we train data analysts to understand the design so that the data could be entered both with relational and non-relational way, so you could do predictive modeling. Then we're training people who understand health services research so that the data could be then applied into clinical work. So all this requires integration. So we're actually training integrators that understand more than one field. So this integrator will need to understand data analytics and the medicine. This integrator will need to understand the engineering piece and the data analytics, and vice versa. This one will need to understand the clinical workflow and part of the engineering and mobile devices. So gradually, we are already paying, this is in the United States, we're already paying for remote patient face-to-face services via live videos. We're also paying for looking at x-rays remotely. We're paying for that already. Some home telehealth services. There are lots of pilots now in the United States in different states because ultimately if you could show cost savings and better outcomes, right? So that's improving value for the patient. You improve outcomes and decrease healthcare costs. You just improve value. So can we show the video, please? So this is what happens when it's applied internationally during a crisis. So this is the Haiti earthquake, and it's reverberating throughout the region, and lots of people send volunteers, lots of equipment, lots of resources, but nobody could locate them. I have at least 20 of my colleagues went to Haiti right after the earthquake. But nobody could find the equipment because they're all from different agencies. Nobody could do order fulfillment, right? You guys do it all the time, right? Order fulfillment. There's the need and how do you fulfill it. But it turns out that this type of thing is very poorly done. Even today in Ebola, in West Africa, this is very poorly done. So information technology, for example, could be used to triage some of these. So there's an organization called Shiri. They allow people to send either through a text or email or web, and text your needs to this number. And so people will text their needs, and then they map out how many people have an emergency, and it will be, in this area, how many people have threats, how many people have urgent issues, how many responses, and so they could track based on these texts. And then you could, with a technology like RFID or Zigbee, you could actually track individual patients on what they have gotten, including immunizations. and you could put their picture in the ID card, and so forth. So I'm going to transition a little bit to some of the work that we're doing from Stanford to Taiwan, and I want to put in a plug for Taiwan, just like what Nikki did. Okay, so we believe that Taiwan has a unique opportunity here because of the clustering, the industry aggregations, and the foundation it has for high-tech industries. But this needs to be transformed into a higher value industry. And I think healthcare is one of those advanced service industries that we ought to get into. Now, the difference between healthcare and other things is that the advanced service industries not only require software, hardware, but it requires applications. And when you're talking about applications, you're talking about domain knowledge. The domain knowledge in medicine and in healthcare, and you have to integrate them, just like what we're trying to do with the integrated plot with the 3 modules that I told you about. You need to, otherwise it's of no value to anybody. It's just creating more work, right? So we started this in 2001, December 2001, with a whole bunch of MIT buddies of mine. Jonathan was a double E, and then a doctor, and then myself. We have 2 ACES veterans working together to try to build. So the 2 of us are doctors, and then we have 2 engineers, and now we have a team of close to 25 people. We also have U.S. operations now. Benson is also MD PhD from MIT and Harvard HST program. Mark Anderson is our chief scientist and a data algorithm person. He actually is multi-talented with physics, math, computer science, and ended up with a PhD in physics and in math. And so we are trying to build things. And the way we do this is not just building it. We need to know where the need is. So first we'll do a human-centered design exercise on the product that we're interested in building. Then we'll do a rapid prototyping into the hospital setting. Then we'll actually do on-site user testing before we actually finalize some of the products. So I wanted to show you a cartoon of what we're building because I can't show you the real thing. We have them, but I just can't show it in this type of forum. You're welcome to visit us if you like. Can we just show the video?
Please stay still. We will come and help you.
So this is to prevent patients falling from the hospital bed. Okay? And our sensors, there's a sensor underneath the bed sheet and above the mattress that detects 10 times per second what the patient's motion and intention to leave bed based on Bayesian algorithms, predictive algorithms, so that we could tell the nurses ahead of time if the patient is going to be getting up when he or she is not supposed to. And this is sensor technology. This is integrating sensor technology through hardware and software algorithms that we do with sleep studies, that we actually correlate them with sleep studies, that then generates a predictive algorithm from the cloud, so it doesn't matter where the patient is, and then point of care alarm. You will get the signal in your iPhone or in your Android. The nurses will get 40 of them, monitor 40 patients simultaneously, and will do deployment to prevent falls. For that, the opposite of patients falling is when they don't move. It's pressure ulcers. Okay, when they don't move and they're going to build up pressure points, and then the skin is going to break down, and then it's going to deteriorate, it's going to get infected, and you got a big hole in the back. That's not very good. So we also, with the same pad, we could also detect pressure ulcers and prevent them. Can we show the video, please? So again, you see the patient's lying position with the sensors pointing to and give alerts for next repositioning because the pressure points are building up. Mr. Smith, I'm going to turn you to your side because there's a pressure point building up, and that relieves the pressure, turn to the side, and we could monitor the pressure points continuously for years. We actually, because you guys are doing so well with the semiconductors that allow us to keep data for a very large data for a long time and follow the trend. Ms. Smith, you have a pressure ulcer. I will get the doctor, and then come to see Ms. Smith's pressure ulcer, and the doctor will then review the historic data on where the patient's positioning is, and you have to do calculations based on percentages. Put a pillow in between the legs and put some dressing on the pressure ulcer. And so basically, this allows us to take care of large number of patients and know where to look instead of turning everybody over, right? Getting everybody undressed and dressed. Why? That's a lot of work. Some of the primary care doctors in the United States in the weekends have to run on like 100 to 200 patients. They have to go drive to 2 or 3 nursing homes. But what if we could tell them where to look and who needs attention? So basically, we just go from individual tailored interventions to population health sciences, where we could take care of large populations of patients effectively. And I think that is the triumph of the semiconductor industry. It allows us to do that. That's the end of my talk, and I'd be happy to answer any questions. Thank you.
Thank you very much, Dr. Wang. Okay, so any questions from the floor?
Well, Jason, again, and another outstanding talk. Jeremy, you did a wonderful job. Huh? So the question is, when you selected Taiwan as your, experimental environment, what kind of advantages or, disadvantages?
Yes.
How you want us in Taiwan to improve or raise voice?
Yes.
Or this kind of wonderful job can be performed in Taiwan?
Yeah. So let me talk about the advantages, and then I talk about the improvements that's needed. So Taiwan has an incredible foundation in the high-tech industry. And what we're doing is basically we have to build products that are highly reliable, which we know Taiwan can do with the iPhones and iPads, and a relatively inexpensive cost, because we want to be able to reach as many people as possible in healthcare. I talk about the equity issue. So we want to build Toyotas of medical equipment, sensors, solutions, right? So Taiwan has an incredible foundation in that. But what Taiwan lacks is that integration and that innovation. So for example, I sort of grew up half in Taiwan and half in the United States. I moved to the United States when I was 12. And I know sort of the education system here is taking tests every day and try to solve other people's problems. But my kids who grew up entirely in the United States, they do projects every day, sometimes by themselves, sometimes with other people, so they know who's slacking off and who's good to work with, and they know all that team building exercise when they were very young. But for Taiwanese students and engineers that we hire, they are used to taking tests. So if you win, you got to get the highest point on the test. So you got to eliminate some of the competition. That's not good for team building. So what we're doing is we're doing a circulation. So we're circulating our staff in Taiwan to spend some time in the U.S. office and have our staff in the U.S. spend some time in the Taipei office, so the Taiwan folks know how U.S. innovation, in Silicon Valley and other places, how fast people move and what kind of ideas people come up with, the disruptions that people come up with, and the U.S. folks know how to learn how to do the manufacturing process and how make sure to give people the specs that they need on time, because you need to build things reliably and at low cost. So all this is part of an experiment that we're doing. We also have interns from Stanford last year and interns from MIT last year. So we're also inviting interns from U.S. institutions to come work with us. And these are very young folks. Some of them are like teenagers, okay? These are like Stanford 19-year-old, 20-year-olds, and some of them are graduate students. We want our people here in Taiwan to know how much you could do, even though you are a teenager. The potential is huge. Now, we think here that you have to be some sort of, old gray hair to get some credibility, but look at Zuckerberg. I mean, he was like 19, right? So we want to make sure that folks here know, but we try to do the same with NTU. And they want us to fill out a whole bunch of forms and reveal our secrets in the company. We're like, thank you very much. Unless you change your system, we're not going to participate in that kind of thing. I mean, that's just the rigidity of thinking about innovation. I think it's going to, unless it changes in the infrastructure. We sort of had the advantage because when we started this company, we started in Cayman, so that we have the ability to issue stocks, but that's no longer true for a lot of Taiwanese companies and startups. And that incentive, I mean, the ownership of the company, even if you own one share, I mean, if you own one share of Microsoft when it started, you're like a millionaire. The janitors in Facebook are like each racking up $10 million or things like that, if you start really early. So this ownership of the companies is critical. So I think that's something that we have to foster innovation and help to overcome some of the hurdles, both in our training and also in the infrastructure, government infrastructure requirements for startups. Thank you.
So did you get some agreement with hospital that you can do the real tests on patients?
So
Taiwan hospital
Yeah.
agree, and they also offer.
Yeah, so we were very fortunate that when we were starting this idea and we approached Dr. Andrew Huang, Huang Dafu 院长在和信医院. And I know he cares deeply about patient safety and quality of health care. And he looked at this and he's like, we got to do this, not only for patient safety, but for Taiwan, because, we got to make this model work. So they've been so supportive about anything we build, we have to pass through Dr. Huang's high quality standards, which is, very, very high. And then, we've been basically doing, what happens is that we put this in one of their cancer wards, right? And we tested now, I don't know how many patients. Tony, are you here? 650 patient days. No one failed. So that ward, the fall rate in the United States is 4 to 12 per 1,000 bed days. So if you have a 30-bed hospital, and in a month, you're going to have one fall. Okay? So just 30 days. So, I mean, it's very often, right? So, and if you have a 300-bed, hospital, I mean, it's going to, basically, take 3 days to have a fall. So basically, people are trying to prevent these falls, and you have to report it to the government if you have a lot of falls, and they will shut your hospital down. And not only that, you have to pay for all the expenses incurred for the falls. That's a new regulation in the United States. So, and ulcers too. So basically, we've been doing that, and we're now going to Kaiser Permanente. They are in California. They are allowing us to work with them very closely, and with the hope that it will get adopted in their system. But we're working on that, and we're also in Boston, the Leahy Medical Center and Clinic, where it's a tough teaching hospital. So yes, I think that is the barrier to entry. Okay, the barrier to entry is access to the hospitals, but I mean we grew up there, so
Thank you.
We have the key. Okay.
Thank you very much, Dr. Wang. So can you please come here, and Judy will present the speaker gift. And thank you again. Maybe you can.
Oh yeah.
Okay, thanks again for Dr. Wang's great presentation.